Okay, second case. This is a young woman, Jessica, 24 years old, primary prevention with heterozygote FH. Her LDL is 224 on a statin from a baseline of 350 milligrams per deciliter. So she's not a subtle heterozygote FH patient. Her current treatment is rosuvastatin 40 milligrams a day, which she's been doing for 2 years. If she does the right exercise and low-fat diets, obviously she has been talked about her pregnancy protection, which you all should do if you're going to put young women with FH on statins. But I think her PCP has done a pretty good job up to this point, somebody, in talking to her about early intervention in FH to get a lifetime risk reduction. So the question is, what changes would you make to her treatment plan? Okay, so see where LDL was, where it is, the reduction she got on 40 of rosuvastatin, which is a high-intensity statin. So would you talk to her about adding a bile acid sequestrant, ezetimibe, fenofibrate, lomidopide, or a PCSK9 inhibitor?
Lomidopide.
So let me just sort of say, most of you would add a PCSK9 inhibitor. I will tell you that in the ACC-AHA, she fits in group 2, except for her age. They don't really say anything under the age of 40 years old for heterozygote FH. It's usually ages 40 to 75, and that if they're primary prevention or secondary prevention, use high-intensity statin. So she is an FH with a baseline LDL more than 190. She's primary prevention, but doesn't really fit the age range. So does anybody, Joe, have a recommendation for age range in what to do with high intensity or more in statins, add-ons or anything? I mean, this is what they said. Maybe you could consider a non-statin drug after you used high-intensity statins in FH, but they sort of said it was a low evidence recommendation.
Yeah, I think this is just maybe an area that hasn't been studied as well. I'm 21 and up, I'm comfortable. If you think about when you can use high-intensity statin therapy, the one thing that jumps out about this person is that it's a woman of childbearing potential. And it wouldn't hold me back, and maybe when you're in your 40s, there's less of a risk of that, but 21 and up is the point where I would really feel pretty comfortable in using high-intensity statin therapy in this kind of woman because of her presentation, because of her maybe blunted response to her current treatment.
Yeah, we'll talk about that blunted response in a moment. Any trouble with ezetimibe or a bile acid resin being added to a woman of childbearing potential?
Absolutely no problem with the bile acid sequestrant. That's a non-systemic drug that should be viewed as very safe and even compatible with pregnancy. Ezetimibe probably is okay in pregnancy, but it was approved when we had pregnancy ratings, and it's considered a C, so it's a little bit more concerning than a bile acid sequestrant, which is labeled as a B, where we know it is safe. I still would be okay in using these drugs, especially with a bile acid sequestrant, but I think it would require me to do some other things and due diligence with education and other treatments.
I mean, the problem is that she is not a subtle FH patient. She's probably got a monogenetic. You probably listened to some of the gene discussions this evening. To have a baseline of 350, she probably is a monogenetic. You get to that high a level, and they do have very high risk of heart disease early in life. The fact that she responded a little less than you expect to 40 milligrams of rosuvastatin is not unexpected with statins. I mean, some of you have probably seen that happen. You give a patient a statin, and then you see these waterfall plots, and not everybody gets the mean 50% or 55% reduction. Some get more, some get less, and there's some that don't even respond much at all to statins, which we don't understand completely, but they are hyporesponders to statins. She seemed to got less of a response than you would expect. This was an interesting paper by Paul Ridker. He was saying using these kind of LDL response variabilities, you might consider this in allocating a PCSK9. So he was saying that maybe in this group down here, the one on the waterfall plot that gets less than 30% reduction on high-intensity statin, yeah, you're giving them the high-intensity statin. So, yeah, maybe they're getting some anti-inflammatory effect, but they're not getting the LDL effect. So what do? You could add ezetimibe, you could add bile acid resin, but depending on where they are, they need substantial LDL lowering. And maybe with an FH patient, that kind of hypo-responder would be something that you might consider. So that was an interesting thought. It said less likely to use PCSK9s if you're a normal responder and you get the really good response to high-intensity statin. The question I have for her, and this is with the expert consensus panel without ASCVD, they did say you could consider a PCSK9 inhibitor and ezetimibe, but again, most of this is in patients who fit the older patient groups with FH, and there's not a lot of data in young people with FH to use PCSK9s. I will say that the data for outcomes with ezetimibe are in older patients. I mean, it's with patients with ASCVD, which is the Improve It trial. And even when they tried to add it in patients with FH, which was a carotid IMT study, which failed, which was the Enhanced study, it didn't seem to help much adding on top of high-intensity statin. So there's a lot of limitations about ezetimibe there. There is data that PCSK9s work in heterozygote FH very well. Plenty of data with alirocumab lowering LDL at least 50% from baseline, and the same with ibalocumab, reducing LDL at least 50% from baseline in heterozygote FH. So one of the questions I think, Joe, that I was wanting to know is hyporesponsiveness in FH, should that make you think, if they take a high-intensity statin and get less response, could part of that response, is that meaning maybe you should be checking Lp(a)?
I was going to ask you the same question, actually. This might be the kind of patient where you would check Lp(a) to see that may explain some of the lack of response. I mean, clearly, this lady has had some response, not as much as we would predict, and there is some normal variability amongst patients. Not everybody's going to get what you predict, and her reduction is in
35%.
Less than 40%.
Right.
Okay, so that's definitely in that range where I'm thinking, hey, maybe she has high Lp(a). That would explain some of her blunted response. It doesn't mean that you wouldn't still treat her and still treat her aggressively, but it is something that I think has some merit, and for clinicians that actually see these kind of patients, they will more commonly measure Lp(a) to help gauge their intensity of treatment and maybe to modify some of their treatment approaches overall. I think it's really easy in this kind of person to say, at least my perspective, I look at her, I'm like, I really want to advocate strongly for a PCSK9. I'll fill out the prior authorization. I work at a great institution. We have a great team of people that, as overall healthcare team approach to getting these prior authorizations for PCSK9 patients that really need them and meet criteria. This is a woman who would look like it. Some prior authorizations may require the use of ezetimibe. So I'm always concerned. I remember the Enhanced trial, and those were patients with familial hypercholesterolemia, and the results were not perfect study design, but they were disappointing. So I accept sometimes that I might start ezetimibe to, I hate to say, go through the motions, but if I add it on, I would not think it's going to get me to the endpoint I want. It would basically to help me get that prior authorization for one of the PCSK9 inhibitors approved.
Well, getting back to the fact that she's 24 years old, and we didn't get into the history whether she's married, whether she wants kids and all that, but pregnancy issues become a concern. So we talked about ezetimibe, what you felt about the safety of that. Bile acid resins are clearly safe. Monoclonal antibodies, what do you think about the safety of pregnancy?
That's a great question. I know this is one where there's phase 4 data, a mandate by the FDA to look closer at pregnancy in women that develop pregnancy while treated with the PCSK9 inhibitors. We need that data. And there was a change with the FDA a few years ago that we're not going to see pregnancy categories for new drugs anymore. There's a great little explanation provided to clinicians for you to make the choice. So what we know about these are very focused treatments, monoclonal antibodies for PCSK9, which doesn't seem to have any other physiologic purpose that you would predict would cause embryonic damage or teratogenic effects.
They don't cross the placenta.
Yeah, they shouldn't because of the molecule size, right, and that they're monoclonals. So we would think that just like insulin, in large molecules, subcutaneous injection for stability, it shouldn't cross the placenta. So you would expect it to be safe in pregnancy. And a lot of clinicians believe that despite some of the lack of current data.
So that would make you feel a little bit more comfortable if you wanted to take that step. So her LDL's 224. If you were to add ezetimibe, okay, you might get her below 200. Okay, so she ends up at 180, 190. Everybody feel comfortable about that? You may. You could add a bile acid resin on top of that, and you might get her from that 180 to 190 down to 140, 150. But now she's got to take that handful of drugs we were talking about before in order to get down to that range. And she might, but they're all reasonably safe in pregnancy. If she had a high LPA, would that push you more towards not using ezetimibe and a bile acid sequestrant? Would you then move more towards a PCSK9 for her?
I would.
Would everybody feel more comfortable? I mean, I think LPA probably should be measured in all FH patients anyway, but I mean, she would probably one you definitely want to measure because of her somewhat seemingly not as good a response to Rezuva 40 to see if she, and if her LPA was really high enough, yeah, she's got a high risk for not heart disease, but also aortic stenosis, and an earlier treatment paradigm safe for her at her age might be a PCSK9 monoclonal antibody.
It certainly would help the approval of well, you would think that would help with the approval of your PCSK9 inhibitor.
Correct. Now, would anything else help you with wanting to be more intense with her treatment and getting a lower LDL, such as using a PCSK9? Would you do a coronary calcium score in her?
So I personally, as a pharmacist, we don't do much of those in my practice. I'm thinking this is probably a woman that you could, depending on the cost and her availability. I'm not sure it would make me want to be more aggressive because I already want to be aggressive in this woman.
Yeah.
Would you order a calcium score?
I don't know. I mean, if it's 0, is it going to change what you do?
No.
If there's something else that would make you be more intensive, maybe. I think some of us would want to be that anyway. So I think that's probably where we go. I just want to make a comment about the NLA update to what the use of PCSK9s in a patient just like Jessica. They did go in that group between 18 and 39, less than 40 years old, young patients. And they did say that PCSK9s should be used if they have some other comorbidity with their FH. So if their FH is clearly monogenetic gene, they always have high risk, and you should get lower LDL. So if there's a definite gene defect, you probably should consider it in a younger person. If they have high Lp(a), that would be another comorbidity. And if they have evidence of non-invasive vascular disease, that you could consider that a higher risk younger patient for PCSK9 under the age of 40. Yes?
So I don't know that we have a lot of data, but my question is, if she decides she wants to get pregnant, for that 9-month period and or the 6 months she might breastfeed, would you stop all medicines? Would you continue one? Would you continue all?
Well, the question with the statin is we all know, she should stop it before she gets pregnant. So as I always told my younger FH patients, women, I said, I want to be the second person that knows you want a child. And that's when we stop the statin, and then you try, and then you get pregnant, and then you go through breastfeeding, and then we restart. I used to continue bile acid resins and stuff while they were pregnant, at least during that part, if they could tolerate it without the constipation. But the PCSK9s we talked about, we don't know whether you should stop them. It probably does not come out in breast milk. It probably does not cross the placenta. You probably could continue that, but not the statin so far is what I would recommend.
I think that's a good way of looking at it, and I think this is where you really pull the patient and have their choice respected. We had a great lecture yesterday from Ann Goldberg, or this morning actually, from Ann Goldberg in Lipid Academy, and this exact question was posed, and what her preference was, and I'll just share her preference because she has a lot of experience with this kind of thing, is that she routinely stops all therapies but the bile acid sequestrant during pregnancy and throughout breastfeeding to be conservative. Now, if a patient was willing to accept very low potential risk of the PCSK9 inhibitor, I would be inclined to consider that. I think if you think of the finite period, though, stopping therapy and just bridging with a very weak agent like a bile acid sequestrant, or moderate, I guess, agent like a bile acid sequestrant might be the most conservative and yet probably okay approach for that period of time.
Yeah, it's not that big. The only problem is that you get some of these women will have 5 kids, and you're sitting there, okay, this is this is getting a long time here, sometimes without
And
without
potentially
treatment.
pass on that gene, right? So I mean, there's another family planning aspect that's beyond this presentation, that if she really has heterozygous
Yeah.
FH, that her offspring may actually inherit one
Yeah,
of
so
the genes.
you counsel them and sort of say, if you want to have 5 kids, you increase the chances of one of them's going to get your gene. Yes.
So if you chose to put them on bile acid sequestrant during pregnancy, you're monitoring them, are you monitoring their triglycerides and stuff? Because you know how trigs will go up during pregnancy. Do you pull them
Yeah.
off then, or how do you handle that situation?
Well, it is going to be something you'll have to monitor during pregnancy. Particularly, there's a lot of things you have to monitor: weight gain, impaired fasting glucose, gestational diabetes, preeclampsia. There's a lot of other factors that will contribute to their future risk of heart disease, as you well know, because preeclampsia and impaired fasting glucose and gestational diabetes are bad future cardiovascular risk for women. So you're going to have to monitor all those things. But yeah, I think you wouldn't want the triglycerides to go up, and hopefully they wouldn't gain weight and develop insulin resistance and get hypertriglyceridemia, but that would be something you'd have to follow. Well, I think it depends on what their baseline is and then what happens after that. I mean, if it's continually going up, I think, if it goes to 200, 300, 400, yeah, you're going to have to stop it at 300, 400. It may contribute, and you probably should back off of it if it gets to those kind of levels, because if those are fasting levels, then postprandially they even go higher. So you probably need to consider stopping it if they go above 300 or 400 on a bile acid sequestrant.